First of all, could I thank the organisers of this meeting for the honour of being asked to speak, and thank you, Rose, for that introduction. My title is up there before you, and it's very much a personalised perspective learned over the years, including through some mistakes, I hasten to add. But I hope it will be of interest and of use to some of you, or if not most of you. So first of all, a few declarations. I'm speaking in a personal capacity, although hopefully I'm not uttering any heresies. I have done some work for other organisations and received consultancy fees. They are there. The most important declaration is that I am not an engineer, I am not an expert in ventilation, I'm not an aerobiologist, I'm somebody who is a medically trained microbiologist, infection prevention control practitioner, who has tried to understand and interpret the technology and how we can use it best. So what I'm going to do over the next 25 minutes, and I'm conscious of time, particularly as people will be moving off this afternoon and to stick to time, is to say a few words about spread of infections, which may overlap with what's already been said at this meeting. Talk about operating theatres or rooms, which I've had some involvement with for over 30 years in terms of guideline development. Lessons learned from the pandemic and the things that I didn't get right. The implications for patient isolation, and then conclusions and reflections. So first of all, some introductory remarks. Now, this is a really kind of noddy style about infection transmission that you might find in some form or other in an undergraduate textbook. And I just put it up to emphasize to you our traditional understanding and how, in fact, now we need to relook at that. And one of the things we all do, and I'm as bad as anybody else, we love to compartmentalize. We love to put sort of our shirts in one drawer and something else in another. And we like the idea, this bug is one particular form of transmission and this bug is another. I think we have to relook at that. And this slide is trying to convey in a very silly way what I'm trying to say. But let's go back to basics. Why do we need ventilation in healthcare? First of all, for comfort, and I'll talk about that in a minute. In this climate, maybe less so. We don't have severe high temperatures or low temperatures, although that's changing. Other parts of the world, they do. Operating theatres, I'll talk about that specifically. And particularly the prevention and spread of microbes, either because of very vulnerable patients who need to be protected from other microbes or patients who have transmissible infections. And then finally, you have high risk. I'm not going to talk about Ebola and viral hemorrhagic fevers. Those are specialist units. Now, what about comfort? Is there any association between comfort and infection rates? There are some observational anecdotal studies that suggest the pointers in that direction. This is a registry from the United States looking at knee and joint arthroplasties or artificial joint replacements. And when you looked at the graph for both knee and joints, there was a peak in the middle of the months when it would be most humid and warmer. And this was trying to allow for variables that might impact upon that. But that is reflected in other studies as well that I've seen, including surgical site infection. So the question is, do uncomfortable conditions affect infection rates? My view is probably. First of all, temperature and humidity. We know, for example, that in the groin, we have more bacteria, a greater variety of bacteria. That's why we don't put central lines into the groin. So the areas of the skin that are drier certainly are safer. There's probably an impact on the human physiological response, on our emotion and on our psychology. We get irritable. We're probably less likely to perform if it's very hot and very humid, and similarly if it's very cold. And interesting enough, since the pandemic, I've found myself looking at articles in journals I never did before, such as on buildings and materials and ventilation. And one of these is indoor air. And I came across this. This is an article pre-pandemic where a group of architects and engineers looked at the literature from their perspective and came up with some sort of recommendations as to the kind of air changes that you might find, say, for example, in a patient room, in an air-controlled room, in a nursery, and so on. And you can argue whether those are right or wrong, and indeed the temperatures as well. But the point of view is that there is literature out there from the building design perspective. And then the other thing that was interesting in this was the persistence of microbes in the environment, particularly on surfaces. And essentially here we have, for example, if you look at lipid envelope viruses, which include SARS-CoV-2, we see that they survive best in low humidity, whereas fungi, for example, are best in damp, moist climates, or damp, moist conditions. And we'll come back to that maybe in a study we were involved in recently. And then you have human activity. We cough, we sneeze, we talk. Sometimes we talk louder. I remember at the start of the pandemic, a good friend of mine who was in a choir said to me, Hilary, we're no longer meeting for our choir. We're having our practices by Zoom. So the first choir practice by Zoom. Wasn't it wonderful in terms of innovation and intuition? So how we behave, what we do, also affects transmission. Now, before the pandemic, I spotted this very interesting study, mathematical modeling, or if you like, the forerunner of AI, where they were hypothesizing the relationship between the acquisition of coronavirus, TB, and influenza, depending on the time spent in contact with a transmissible patient and the air changes per hour. So, for example, they came up with a figure that if you were in a room with a patient with transmissible TB at 5 to 6 changes per hour, if you spent 15 minutes in there, you had something like a 2% risk of getting TB. Now, whether that's right or not, the point about it is it's trying to put some sort of metrics on relative risk. And more recently, we've had some fantastic studies using computational fluid dynamics, looking at tracking of airflows and simulation studies that have really told us an awful lot about how we transmit respiratory particles or droplets, whether the patient is lying flat. These are simulation studies, whether they're sitting up. And if you look at this, for example, here, we have a series of bar charts. On the far left, as you're looking at it, on the wall, the ceiling, the floor, and so on. And the different colors represent different individuals under different conditions, such as of temperature and humidity. And you can see that most of the particles go up at the ceiling, probably because hot air rises and also because of the ventilation system. So we know far more than we used to arising from the pandemic. Indeed, the pandemic has almost been a paradigm of research equivalent to HIV/AIDS in the early 80s in terms of our immunology in 80s with HIV. I think the pandemic in terms of infection transmission. And certainly, you know, if you look at ordinary things that go on all the time without us being aware of it, one of my earlier interests was MRSA, but we looked in Dublin at MSSA, and we actually looked at samples from, this was outside of outbreaks, we looked at samples from healthcare workers, obviously with consent, patients, clinical isolates, air samples, surface samples. And this is a genetic tree looking at clonal complexes. And if you can just look down at the bottom, number 11 there, you'll see that there are isolates. And again, if you see from the air, from the patient environment, from clinical samples that are all very closely genetically grouped together. So all the time within a healthcare environment and indeed outside, there are different microbes potentially interacting on different surfaces in the air and on individuals, both healthcare workers. And so in fact, we do very well that perhaps we have fewer infections than we might otherwise have. So let's talk about operating rooms. I love this slide. As you can see, the first slide at the top there breaks every rule of equality, diversity, and inclusion. It's all male. They're all in their morning suits, and the patient is hardly of interest. It truly is a theatre, is it not? Hence the word theatre. You can see that 80 years later, there was some semblance of infection prevention in terms of sterile instruments and protective clothing. But what is the purpose and components of ventilation in the operating room? It's to remove anesthetic gases, although most systems are now relatively closed, to provide comfort, we've talked about that, but particularly to minimize risk from airborne microorganisms of whatever means, through filtration of supplied air, dilution with high air changes, 22 air changes per hour thereabouts in a conventional theatre, and making sure that the differential air pressures are such that they're highest in the areas most important, the preparation room and in the operating theatre. Now, this is best described in the next two slides. A slide I owe Craig McIntosh. On the left is a time course analysis, and on the vertical is bacteria carrying air particles. And if I can just bring your attention to the biggest peak. The biggest peak occurs when there are 5 people rolling over a patient. So the number of patients and their activity gives you these squames. These are what we all shed all the time, mostly with staphylococci, probably most of the time coagulase negative staphylococci. Put this another way from a slide from Peter Hoffman. You can see outdoor air, lots of bacteria, some fungi. You have that outdoor area, you filter it, and you find that there's very little on it. Then you have 6 people come into that area and they begin to shed bacteria. But when they start moving around, you exaggerate that shedding even more. So if you look at operating theatres, what is the evidence that ventilation actually reduces surgical site infection and other infections? Well, actually, it's very anecdotal. because it was introduced on the basis of, if you like, biological plausibility, and realistically so. And a lot of the evidence, we looked at this some years back, but essentially it's the same since, because nobody would ever do a randomized controlled trial of doing a mastectomy in an operating theatre with or without ventilation. And a lot of the studies were really sort of look-back exercises. A lot of them were combined with other infection prevention control measures, but generally the evidence suggested it does play a role and it's biologically plausible. Probably the best studies have been done for arthroplasty, that's artificial hip and knee replacements. And this is the Lidwell study from the early 80s. Now, this has come in for some criticism recently, but to be fair, it was a very sophisticated study at the time. It was multi-center. They allowed for a number of variables. They did air sampling, and they found an impact for ultra-clean ventilation, antibiotic prophylaxis, and the so-called spacesuits that are probably not used anymore. But they didn't control for the use of antibiotic prophylaxis. It was left very much open to the surgeons, and a post-hoc analysis showed that the greatest reduction was surgical prophylaxis. And therefore, a number of registries and studies have been analysed, suggesting that it doesn't have an effect, such as in this meta-analysis in Lancet Infectious Disease. And if you look at the odds ratio, they are around 1 or even less than 1. So there's been pushback in some countries, but in fact, ultra-clean ventilation means different things to different people in different countries. And in many instances, it's not the same. So, for example, the size of the canopy, the airflows, the standards that are set are not the same in every country, and they may not be used correctly, particularly if you have the exposed instruments outside the canopy. Now, NICE in the UK have decided on this, and they've basically come down largely in favour of the continuation of ultra-clean ventilated theatres for joint arthroplasty. But this is an issue that is going to be continue to be looked at, because ultra-clean ventilated theatres are expensive, both to build and indeed to maintain, because of their energy requirements. We can have a discussion about that afterwards if you wish. So that's the summary of NICE. The committee consensus was that UCV is more effective at reducing SSI, and the evidence review is not strong enough to alter current practice. So it's not an unequivocal, enthusiastic endorsement, but it's basically saying, by and large, we're still in favour of ultra-clean ventilated theatres. And just as a quick advertisement, some of us have been involved in a guideline document on theatre validation, or previously called commissioning, and verification, which is regular review, which has gone in for publication, will be in the Journal of Hospital Infection. These are our recommendations on validation as an example. Good practice points are those where we think it's advisable, but there's no great evidence for it. And I hope that it'll be of useful to many people in hospitals. So the lessons learned from the COVID pandemic. So I first of all have to admit that I got a lot of things wrong. I underestimated its transmissibility. I didn't think there was any way by the end of 2020 we would be administering vaccines to members of the public. So I put up my hands and say I got a lot of things wrong. We've learned a lot about the pandemic. It's now not just a respiratory illness, it's a multi-system infection. And if you think about that, that has to mean its means of transmission have to be much more sophisticated than one or other. But there were huge advantages from the pandemic in terms of what we've understood. Fantastic surveillance systems able to find out patterns of transmission, rates of infection at a very local level because of the digital revolution and rapid molecular testing. And interesting to compare prevalence over time in a certain area, but also between different countries and why. And obviously the UK has had its own review and investigation, and we're going through that in Ireland as well. And we need to learn from that, and I'll come back to that later. So what do I think impacts on the transmissibility of a respiratory virus? Now, I'm very conscious of the fact of the speaker who's coming after me and all the wonderful papers and opinion pieces she has written, Trish, and I hope I feel kind of a little bit intimidated because you know far more about this than I do. But here's my thoughts for what they're worth. Here are some of the reasons. The biology of the pathogen, although probably not as significant as we think. The biological load, in other words, how many viral particles. Whether we're symptomatic or asymptomatic. The stage of the illness, whether we're immunocompromised or not, probably shedding more. Human activity, are we shouting, are we speaking, are we moving around, are we sitting up, are we lying down? The airflows, the temperature and the humidity, and then all the unknowns. And what's really great about some of the studies that came out from the pandemic was the way we were able to trace the pattern of an infection from, if you like, the pre-symptomatic and perhaps pre-shedding, and particularly when shedding, out to be able to say what might have happened at particular points in the time course of an infection and where it's most transmissible, bearing in mind that just because you've got a PCR test that's positive, it doesn't necessarily imply that there's viable virus that results in transmission. So it's much more sophisticated than saying positive test equals transmissible. But certainly there are indications there as to what factors you would take into consideration when looking at transmissibility. And then there's human activity. So for example, high-risk procedures, aerosol generating procedures such as intubation, such as bronchoscopy, such as suctioning, clearly are a higher risk, will generate lots of different particles of different size, a risk to other patients, but also a risk to patients. And then we had some other interesting surprises. So this is the fecal aerial transmission of SARS-CoV-2. So this is a study from China published in 2020 where basically they had 3 families living in 3 different apartments practicing social distancing with 9 patients becoming, or 9 individuals becoming infected. However, one of them had been in Wuhan at the start of the pandemic. And basically, I don't know whether you can see it or not, but basically on the left as you look at it, you're seeing the toilet in each of the apartments. And what basically happened was that although the effluent was going down, the aerosols generated by the flushing were going up the shaft, up to the next level where patients who were social distancing became infected. Absolutely fascinating description of a variability in transmission of a respiratory virus nobody would have ever thought about. And this was used subsequently to trace patterns and epidemiology of SARS-CoV-2 in effluent, and often that was actually that often gave us early warnings of clusters of cases or a peak in incidence. And in hospitals, this is a study from Dublin, they looked at basically hospital-acquired COVID. This was the red dots amongst patients, or the red bars amongst patients, and the blue dots were healthcare workers. And they did whole genome sequencing, and there were 6 clusters. And essentially, they came to the conclusion that the study provides evidence that transmission occurs from symptomatic and asymptomatic healthcare workers to patients. The majority of transmission is spread probably by droplets and contact on the basis of temporal and geographical evidence, but clearly lots of situations where they couldn't explain it. And SARS-CoV-2 is spread very widely. We saw a lovely slide earlier this morning of the splashing from a sink. So you imagine somebody coughing or sneezing, and they're going to spread particles of different sizes that are going to spread in different directions and in different lengths depending on how much energy was expended in the cough or the sneeze and what the airflow is. And this is a study from the States where 20% or 14% rather of surfaces were contaminated with SARS-CoV-2, even though many of those surfaces were quite distant from the patient. And even when you look at what happens in different variants of SARS-CoV-2 and whether patients are vaccinated or not, this was done in the United States. They found that the ancestral, if you like, variants of COVID-2 were less transmissible than the ones that followed, even when patients were fully vaccinated and had booster dose. And if you remember, we got the sense it was becoming more transmissible, but patients didn't seem to be as ill the second or third time around. Now, that's partly because of prior exposure and maybe a degree of immunity, but it may also have meant that basically the virus was trading transmissibility for, if you like, virulence. But even when we have the facilities that are correct, we don't necessarily use them correctly. So we have this situation here where we have basically single rooms with air-controlled ventilation, but they left the doors open, so you had 3 patients on the other side of the corridor getting SARS-CoV-2 because the doors were open. And even in influenza, which people would argue isn't aerosol transmission, this was a study from Hong Kong before the pandemic, and basically there were 9 patients infected, indicated by these kind of white rugby balls, because of the airflow was unopposed going down the length of the ward. So the airflow was important. So implications for patient isolation, we need to first of all decide what is an isolation room, and people have different views. Is it for, say, somebody who is terminally ill? Is it for somebody to prevent healthcare-associated infections? I think we're moving towards single rooms for most of our facilities, particularly I know the new hospital building program in the UK is, and that's brilliant. The trouble is most of us are working in hospitals that were built 20, 30, 40 years ago. So single room is by and large advantageous, although there are some disadvantages, such as, for example, staffing issues, also patient isolation, psychological isolation, and issues more falls, for example. And you're very fortunate in the UK. You have some wonderful documents that are used internationally, not just amongst English-speaking peoples, both health building notes and health technical memoranda. And this one here, a health technical memorandum, I think it's 2021, indicates the 3 categories of patients on infection grounds that need to be isolated. I think the third category is the most difficult of all. There are lots of patients now in our hospitals and indeed our healthcare premises who are not in the first 2 categories but are at risk because they're some years after a transplant, maybe they're on biological agents, maybe they've got uncontrolled diabetes mellitus, and trying to work out which patients should go into an isolation room is difficult. There are specifications as to what the isolation facilities should be, and those are well known by your estates and engineering department, but probably worth liaising with them. And I'm certainly of the view that in critical care, if at all possible, we should have single rooms. But not necessarily do the critical care community believe that. As you can see from this document from the Society of Critical Care Medicine in 2024, because they're looking at other aspects of patient care, such as the frequency to go in and out, and the other issue would be equipment. And we have sort of indications for positive and negative pressure rooms, depending on whether the patient is at risk or whether the patient has a transmissible infection. And the traditional way was we had a flick, we flicked it from negative to positive or back, but the worry was always that we had the wrong categorization for the individual patient. We've now moved, I think it's true in the NHS, to neutral ventilation lobbies, neutral patient rooms with a positive lobby and a negative, if you like, en-suite facility, so you can isolate all patients in that particular room. We did some verification of this recently, and we found that it was fit for purpose, as we hoped it would be. Very little, the only Aspergillus we found was in a damp area in the en-suite facility. What about old solutions and new solutions? There are lots out there. We heard a wonderful talk earlier from Dr. Weiser on air hygiene and what we can do. We've looked at cold plasma, but it's not yet ready for use in the clinical area. I thought this was very interesting. These are laser-induced graphene filters that you can heat to very high temperatures and reuse again and again. And you can see that in the lower graph. The red is basically the number of particles that you will find, but obviously quite expensive and sustainability issues. A combination of HEPA and ultraviolet was used in Cambridge at the peak of the RNA, or at the SARS-CoV pandemic. And if you look at this on your right, you'll see that with the air filters on, far less carrying particles of both coronavirus, but also other bacteria and indeed fungi. And there's fairly good evidence for ultraviolet, even though there are some limitations. But a lot of the studies show reductions in the numbers of organisms. It's very difficult to show true reductions in infection because infection is multifactorial. And so I have some sympathy for the technology companies in trying to show that. They require very sophisticated studies to show that. And therefore, at the moment, I like this kind of conclusion from the Australian Commission, which says that emerging technologies to filter and clean air used in combination with mechanical, natural, and hybrid ventilation, or consider where other ventilation strategies are not possible, and they list some of those that they would agree with. So conclusions and reflections, I think I'm okay on time. So we've had to re-look at all our concepts of infection transmission and maybe not have such simplistic views. It's not that we throw out the baby with the bathwater, but we realize that there are other factors simply because it's MRSA, it has to be only contact. I love this article spearheaded by Stephanie Dancer, who will be known to many of you, who looked at various myths and then looked at the evidence for or against. And basically, and I know we're going to talk about masks in a minute, so I won't go into that, but positive view on masks. We also have to learn from the past. Hong Kong had a big problem with SARS in the early noughties, and they learned from it. They improved the provision of PPE, they built a number of single rooms, they increased the number of air changes per hour, and Hong Kong, Japan, and South Korea fared better in the first phase of the pandemic than we did because they had put in some measures to deal with it. And so I think we now need to learn from the inquiries that are ongoing. We also need more flexible, better designed hospitals that we can actually deal with surge capacity when we have infection. And a few of us tried to summarize our thoughts on this recently. Making sure that patient flow is sensible, making sure that we put people in the right place, making sure that we have flexibility and that we can allow for surge capacity, such as, for example, converting an outpatient into, for example, a clinical area. And the engineering and architectural world is also doing this. Another wonderful article from Indoor Air. A lot of it is beyond me in terms of its technical, but looking at research priorities and knowledge gaps, such as methods, develop standardized methods for investigating risk of infections, knowledge gaps, how to implement effective controls in building at scale. Really interesting. And one of the lessons we have to learn, and these are the lessons, is that we must learn and be prepared to review assumptions about infection transmission. Operating theatre ventilation must be used correctly, including for ultra-clean void arthroplasty. COVID was the perfect storm, and we learned an awful lot about it, and we need to build on that. Circumstances, particle size, airflows, the use of measures, all matter and all contribute. There's no one measure to prevent infection. We need sufficient fit-for-purpose symbol rooms or appropriate. Technology has a role, but there are economic and other issues such as sustainability that need to be considered. And I think if there's one message that I want to come out of this is, we must work as part of a multidisciplinary team when we look at our building infrastructure, both in terms of its maintenance, in terms of our commissioning, in terms of its design. So if you haven't already done so and you're involved in areas that I've talked about, make sure you have a good relationship with your estates and engineering department. Thank you very much.